Hello, Dr. Brennan and classmate. My case presentation today is about rotator cuff injury. I chose this case presentation because I don't usually see patient that has a rotator cuff injury in the clinic. I do see shoulder dislocation in the ER, but not. I haven't really managed a rotator cuff injury. So this patient I saw last week. She's a 68-year-old Hispanic female who presents to the clinic with a 2-month history of right shoulder pain. So on her own, she's a reliable historian. She speaks fluent English, and she does herself to the clinic. On her own statement, she said that like my shoulder has hurt for almost 2 months now, and even like lifting my arm to brush my hair hurts a lot. So for her history of present illness, Miss GM is a well-appearing 68-year-old female with a significant medical history of hypertension. She does have diabetes. She has dyslipidemia, who complains of right shoulder pain. She described the pain as dull and aching and has a gradual onset. The pain has been going on for 2 months, and she denies any trauma, no injury, or falls associated with the pain. However, though, she said that she works as an office clerk and usually carries heavy papers and folders. She also states that she goes to the gym like at least every other day, and then she does like cardio workout. She reports that it affects her daily activities due to the right shoulder's limited range of motion. She haven't seen any provider about her condition, and then she said that she has just been taking Tylenol with minimal relief. She denies any fever, no chills, no sick contact at home, and then there's no weakness or numbness or tingling sensations on her right shoulder. So her past medical history, she does have hypertension, which she takes hydrochlorothiazide and lisinopril. She's diabetic. She's taking metformin, 1,000 milligram twice a day, and then hyperlipidemia, which is take atorvastatin. No past surgery in the past. She said that like her immunizations are all up to date. Healthcare maintenance. She just had her colonoscopy and mammogram done 3 years ago. And then family history, her dad has diabetes or has hypertension, and her mom has diabetes. Social history, she denies cigarette smoking, no chewing tobacco, no alcohol use, no drug use. She is divorced, and she lives with her youngest daughter. And then for review of system, she denies any constitutional symptoms, no fever, no chills, no intentional weight loss or weight gain, no fatigue, no weakness. Cardiovascular, she denies any chest pain, no palpitations, no shortness of breath, no irregular heartbeat. Respiratory, there's no coughing, there's no difficulty breathing, no difficulty breathing or shortness of breath too. Neurologic wise, she denies any numbness or tingling sensations, and then there's no weakness. Musculoskeletal, she reports the right shoulder pain, especially with active range of motion. Physical examination, general survey, Miss GM is calm and she's pleasant, healthy and non-toxic appearing woman. She is alert, oriented, and not in acute distress. Her heart sounds are regular. S1 and S2 are heard. There's no murmur or gallop appreciated. Respiratory, lungs are clear to auscultation bilaterally. And then for musculoskeletal, I did check her left and right shoulder. I did the left shoulder examination first, and then it reveals like inspection of the left shoulder joint reveal there's no swelling, there's no deformity, there's no joint asymmetry, there's no limitations on range of motion like flexion, extensions, abduction, adductions, or internal rotation, and then there's no pain elicited on passive and active elevation of her left shoulder. And then on the right shoulder, there is like movements are restricted with active elevation limited to 45 degrees. There is restriction on internal and external rotation. Movements are painful with active and passive elevation. And my preceptor showed me how to do the belly press, in which like the patient will put her hand on her belly and then press it, and then it will produce pain on her right shoulder. And then there's also the so-called lift off test, in which her arm will push against the bed as if she was standing, and then that maneuver will elicit pain on her right shoulder. I also did the empty can test, which also showed positive result. Vital signs for her: blood pressure is 136/84, heart rate of 75, O2 at 98%, respiration 18, temperature 98.6, pain score is 6 out of 10. For her differential diagnosis, I do have shoulder dislocation, shoulder impingement syndrome, and my most likely diagnosis is rotator cuff injury. Shoulder dislocation. Usually, patients with shoulder dislocation often experience like severe excruciating pain, and then there is decreased range of motion, and then this is often due to traumatic injuries such as sports, assault, any falls, throwing object, forceful pulling and pushing. And then this is least likely diagnosis for her because of the mechanism of injury, which is usually traumatic. Then the shoulder impingement syndrome or the subacromial impingement syndrome or SIS. This is a condition in which structure around the glenohumeral joint or the ball and socket of the shoulder get pressed on when the shoulder is raised. So this causes persistent pain and dysfunction, and this is common complaints in a primary care clinic. Then my final diagnosis or the most likely diagnosis is rotator cuff injury. This is a condition causing shoulder pain during overhead activities, mainly when lying on the affected shoulder or affecting the lateral deltoid, causing discomfort at night. Painful daily activities may include putting a shirt or brushing hair. So the plan for this patient is that we ordered a right shoulder x-ray with AP and scapular views and pending results for that. For medication, we did prescribe her NSAIDs and Tylenol, acetaminophen, so naproxen 500 milligram twice a day for pain, and then acetaminophen 500 tablet every 6 hours for pain. And we also did lidocaine patch 4% to apply on the right shoulder 12 once a day, 12 hours on and 12 hours off. There's no referral for now, but she might be referred to physical therapy if pain persists. For patient education, there's a growing evidence that combining Tylenol and NSAIDs may provide improved analgesia for this type of acute injury. Then cryotherapy or ICE is believed to reduce swelling and inflammation in the rotator cuff and adjacent bursae, and providing analgesia and improve isometric strength during acute injury is important, particularly in case of tendinopathy. Modifying the level of activity as well and avoiding aggravating tasks such as lifting is a vital part of resting. Then mobility exercises prevent shoulder stiffness and adhesive capsulitis complication, requiring full shoulder range of motion before strengthening exercises. Follow-up plans for this patient is a 2-week appointment was made to discuss the X-ray results, the evaluation of pain, and possible physical therapy referral.